Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning to my podcast. I always love being here and love spending time with you guys. It's a Saturday where I am right now. It's a sunny day. It's beautiful. I got my dogs hanging out. I got Justin here. And we just finished doing that series on PMS. And like we've recently done, we're trying to find our rhythm. It's been about two years. We're starting our third year now on this podcast. You know, we're trying to find our rhythm in the sense, what I'm saying that is like, we're finding the way we communicate with you. And we're finding that through listening to you and seeing what you ask for and what you like. And so you're seeing a format start to come out of this. And we have a series where we'll have, like, we discuss an issue we want to treat, we want to talk about. We'll talk about, like, say, PMS in this sense. We'll talk about what it is, what symptoms look like, what it feels like for people, why it's happening. We talk about how we diagnose it. We talk about how we treat it. So we do 3 episodes on that. And then we'll circle back on the 4th episode. And during that time when the first 3 are being aired, we're going to be spending time looking for your questions and finding good questions in there that we think that a lot of other people would benefit from having those questions answered. And then we do a whole episode on just answering questions, which is what today is. I see some of your comments on this, the PMS one. It always it hits me close to home. It hits me in the heart. I love doing this work with you. I love being able to provide this information and be helpful for you. I feel this is a very empowering thing for you as women to understand how you can be seen, how you deserve to be seen, how I see you as a professional. I think when you have that perspective of knowing that this is available, you start to ask for it more, you demand it, and you have every right to demand it. You have every right to demand that type of care from your providers, the type of care where you feel seen and heard, understood, not rushed, not blown off. And I think that when you go and you require that, you request that, you create the demand for it, you find more doctors stepping into that space and providing it. So today's episode is going to be me going through your comments and your questions. Mostly your questions, rather. I'm going to be over your questions that were posted in the comment section, mostly on Instagram, because that's where we get them all. That's where we get the most hits in Instagram. I know we post the podcast on Podbean, and we get it out to every platform you could think of. And it's on YouTube is our primary platform. And then after that, we disseminate it. But it just seems like the reels get the most attraction. People are more interested in getting these little snippets from us. So that's where I get my most feedback. So I'm coming from there. But I want you to know, if you see us on YouTube and you write a comment on YouTube, I will see it. We will look for it. We will get it for you. And we do look there too. And I prefer using YouTube because a lot of times we get questions. I was like, well, if you watch the whole episode, you would have got your question answered. So anyway. I'm going to start with the first question that I got that grabbed me. And this one was, I was on the pill for years and still experienced PMS though. Does that mean my estrogen has always been higher than my progesterone? We've always been fobbed off and told it's normal to have PMS. It's not that it's normal. It's just common. And we've accepted something that's unhealthy as normal. And it has been lazy on the part of medicine not to address that. So I just want to say that. When it comes to oral contraceptives, please know, it is a synthetic compound you're taking that is not a natural hormone. And why this is important is that the synthetic progesterone that is found in oral contraceptives has no real benefit to your neurotransmitters. Synthetic progesterone does not cross the blood-brain barrier and bioconverts into allopregnanolone. And that's all nerdy talk there. But what it really means is that progesterone, when you have normal levels of it, it's an anti-anxiety agent. It binds the same receptors that Xanax binds onto, or any kind of benzodiazepine. It's an anxiolytic is the technical term for it. And so natural progesterone is a wonderful buffer for anxiety. That's what it's made to do. That's what it does. And when you take oral contraceptives, you don't have that. That's not happening. So when a woman takes oral contraceptives and still has symptoms, it is largely due to the fact that they're using a synthetic compound. So please know that it's a common thing. And when I have this come across me in clinic and I have a patient, she's on oral contraceptives, I want you to know I don't like oral contraceptives. I just don't. I know they're important. And I'm not against women having contraceptives at all. What I am against is the lack of research and care and development into a better alternative for women, or even just something for men. So just, I'm very much frustrated by the fact that we have this oral contraceptive that's been out for, 50 plus years now that has had little to no changes done to it since it came out, other than just reformulating the same compounds. But these compounds are synthetics that have the same side effect profile. They're not good. I don't like it for that. With that said, coming down off my staying on my soapbox there. Let me come back on my soapbox. When a woman is on oral contraceptives, I'm not going to tell her to get off of it. If she's using it for birth control, I'm not going to tell her to stop unless we have some other better method of contraceptive to use. So how do I manage a woman who has PMS symptoms while she's on oral contraceptives? I will prescribe her oral micronized progesterone. Oral micronized progesterone is the bioidentical version. That's what I prescribe to that woman. Once I give her that oral micronized progesterone, I use that and I run the lab to verify I got the right level. That is how I treat those symptoms that they have while they're on contraceptives. So I hope that answer helps. Another question that came out, how do you even test when on birth control depot? This is the tricky one. I know what's going to happen when I run a lab on a woman who's on contraceptives. I just know what to expect. I know there'll be a suppression of estradiol and progesterone. So I know those will be very, very low in her labs. So when I run the lab, a lot of times when they're on contraceptives, it's to confirm what I already am aware of. Other times it's because there's other pathology occurring around the birth control. Like when a woman takes in oral contraceptives. I know you said the depot, but let me go oral really quick with you here. When a woman is using oral contraceptives, it's going to have a very fast conversion rate to something called estrone. Estrone is a version of your estrogen. It's a part of your natural estrogen metabolism. It's a natural thing to have in your body. It's okay to have. But when it's elevated, when it becomes supraphysiological, is when there's a problem. So when a woman takes oral contraceptives, she will hyperconvert her estradiol into estrone. Estrone levels will become higher than they should be in her labs. Estrone is an inflammatory estrogen, so when it's very elevated, we have a problem. When estrone is supraphysiological, when it's very high, it's very inflammatory to breast tissue, and that can create a lot of breast pathology that we do not want. So I do run labs with women who are on contraceptives to understand downstream metabolites and those risks associated with them. Often women are prescribed oral contraceptives without a doctor spending any time labbing them and testing them for the downstream metabolites. Another one would be sex hormone binding globulin. When a woman takes in oral contraceptives, it will always cause sex hormone binding globulin to go high. It will always do that. It will always do this. With that said, sometimes if you take oral contraceptives long enough, it will cause sex hormone binding globulin to become permanently elevated. When sex hormone binding globulin is elevated, the problem with that is that will cause you to have little to no free testosterone in your body. Now, you need testosterone just like I need estrogen. You need testosterone as a part of your biology. It plays a role with libido, confidence, assertiveness. It plays a role with your boundaries. It's a fascinating thing when it comes to brain chemistry, but also plays a role with balancing estrogen. Progesterone is the primary thing that offsets estrogen stimulation. Progesterone offsets that, but testosterone also helps that. So, estrogen causes things to grow, progesterone causes things to mature, testosterone helps with that. If you just have estrogen without progesterone, without testosterone, you're going to have a lot of those estrogen-stimulated symptoms of breast pathology. You're going to have, mastectomy, where the breast pain with your cycle. You're going to have thickening the lining of the uterus. You're going to have painful periods. That's estrogen dominance. We don't want that, so we use progesterone to balance it. But also we need testosterone. So when a woman takes oral contraceptives, they're going to be low in testosterone. It's important for us to be aware of that. And as any time a doctor prescribes you a medication that could create lasting and permanent impact on your body, it is the job of the physician to make sure you're fully educated on that so you make an educated decision. So when I run labs on women who are on contraceptives, I am thinking about all of these things. And I know that's not quite what you asked here, but it's just, I'm using this question as a springboard to talk about things that are not talked about enough in medicine. Largely you're being experimented on. When they give you oral contraceptives, they're just like, well, let's just see what happens. And they don't think about you as a human being. They don't think about the permanent impact it has on you. They take a lot of liberties without a lot of permission. The depot, with that one, there's not as many downstream metabolites. I'm not as worried about that, but I am worried about suppression of, progesterone, of course. And so I'm going to make sure she has enough progesterone. And if I need to give her some type of progesterone support during the time that she's on the depot, which is a synthetic version, because you need the natural one to cross the blood-brain barrier and have that benefit. When I give a woman progesterone when they're on oral contraceptives or a depot, does that affect the effectiveness of their birth control? No, not at all. Not at all. This is more something that's going to benefit the brain chemistry. That's why we prescribe it. And we monitor all of these things. Can you recommend treatments for PMDD? I'm going to do that in the next one. The next series we're about to do is going to be more on PMDD. Right now, once we're finished with this Q&A, I'm going to do a series on menopause. And then after that, we're going to circle back and do PMDD because it deserves its own series. Now, a lot of people think once I treat PMS, it's going to treat PMDD. To a large degree, you're going to get some success. And sometimes you will have complete success, but sometimes you need a little extra push in there. So I'm going to do a series just on PMDD, and that'll be my next one. So please stay tuned. At age 40, my progesterone was 13.1 and my estradiol was 298. Is this bad? No, that is really robust. That is a good one. So this came from an episode where I was talking about the relationship of estrogen and progesterone. And you do want to be aware of where your hormones are. And sometimes, you'll hear me say, this is a 280, it's too high. 280 of estradiol is not too high. Wait for a minute. It's not too high so long as progesterone is present and in balance with it. So what I was talking about in that episode is really important. Here's your estradiol. Here's the reference range. There's the low and the high end of the reference range. If your lab comes back and the high end of the reference range for your estradiol, and we do your progesterone and it's at the high end of the reference range for progesterone, we're good. That's the key to that. And that's what this woman was. So this is actually a very good level. A woman here asks me, can you give the names or brands of progesterone and estrogen? Do you need a prescription, or is there something in health food stores? There used to be a few things in health food stores where you could buy oral progesterone, naturally occurring progesterone derived from yams. Those are no longer really available in the States. I'm not sure how they are abroad. I'm pretty sure they're not available abroad as well. The brands that I use, I a lot of times I'm using stuff from a compounding pharmacy. I try not to advocate for a pharmaceutical brand ever. It's as a physician, I want you to know that I am not beholden to a single pharmaceutical industry or a pharmaceutical company. I don't have a kickback from anybody, and I refuse that. I'm not an insurance-based physician, so I'm not, told what to say or how to practice or how to be. So when it comes to this with hormones, it's important to know that when you see a hormone being prescribed to you, progesterone, the micronized progesterone, that's it. That's the key words to it, micronized progesterone. If they say progestin or anything that's a synthetic like progestogen or any other weird word in there on the label, that's a synthetic. If it just says progesterone, it says micronized progesterone, that is a natural progesterone. Often you can only get that from compounding pharmacies. You still have some pharmacies will carry it. It is a commercially available product. Not a lot of pharmacies carry it, but you can try and get that. Prometrium, I'll say this. Okay, I'll do that. Prometrium is a brand name for a progesterone that is done in a liquid gel cap, and that's oil-based. It's oil suspension in peanut oil, so it doesn't always work well for everybody. But it is a product that is a bioidentical, that is a commercially available one, kind of pricey. In the States, last time I looked on GoodRx, which is a discount platform where you can find discounts on pharmaceuticals, it was in the neighborhood of $600 for a month's supply. And that's insane to me. I think women should be paying 60, maybe 60, maybe 80. 80 is a lot, 60 is a good amount, I think. At sub 60, I have a lot of women who are going to be on maybe $10 to $20 a month for their progesterone cost, for micronized progesterone. So this is not a very expensive thing relative to other methods of delivering. Now, how about the ranges for hormone replacement therapy in women over 50? Think elephant in the room cohort. I love this. You're the best. That's my next episode, my next series. I got you. I'm going to do your levels that I want to have and all that. That's my next series. You're going to keep an eye out for that. The next one was, would you explain compounded troche progesterone? First time finding you on Instagram and very curious. Thank you so much for that. I prescribed progesterone starting out in 2004. It was an over-the-counter. It was called Progon B by a company called Bezwecken. It was over-the-counter. I don't think they're around anymore. And it was an over-the-counter, easily prescribed progesterone. Now, it had good effect. It wasn't pharmaceutical, though. So it was hit or miss in effectiveness. And that's how I started with progesterone. And then I tried, once I got further and further into practice, I tried every other different method of prescribing. I tried the prescribed, the oral micronized progesterone in the capsule with the powder. I tried prescribing Prometrium. And I went down these different roads with creams. I tried different creams with patients. And over the years of practicing, I will tell you the best absorption I've ever seen that's consistent that I can rely on is when it is a sublingual, something like a lozenge you dissolve in your mouth. So a troche is a medical term or it's a pharmaceutical term. That's where they make a little lozenge that's made with a gelatin. You could do vegan ones. It doesn't have to be meat-based. It could be vegan. It doesn't have to be gelatin. But it's one of those things you dissolve in your mouth, and the progesterone is in that lozenge. And so, the mucosa, the tissue inside your mouth is so thin, it allows progesterone to cross over so easily, you get the best absorption. So if I'm giving you 100 milligrams of progesterone that's dissolved sublingually in a troche version, you're going to have the highest absorption rate. If you take the same thing, you just swallow it whole, you're going to have your diminished returns. The thing is, progesterone, when you swallow it intestinally, you don't really get a great absorption on it. So that's why I prefer using that method of delivery. Now, I do have exceptions, and I had one the other day. Yesterday, I had a woman come in, and she was absorbing like a boss. And it's rare that you see a woman who takes the capsule with the powder in it that absorbs it well. I love that. That's actually the cheapest way of getting it, And I know it's not always about money, but it's important as a physician. I'm aware of the cost of these things because insurance doesn't like to cover it. So I always want to make sure I'm aware of costs and how can I get it delivered to them in a reasonable way where it's not going to break the bank and they can stay on it. It's important. So with the progesterone, I do the best that I can to make sure the price point is good. So if you can absorb that capsule with powder, I'm all in. Okay, next question. Many women feel really crappy in the luteal phase of their cycle due to high progesterone. High progesterone, low estrogen is not good. I'm quite progesterone intolerant. Even micronized progesterone orally makes me feel dreadful. Ruby shoes, I feel you. This has been the bane of my life since I came across it. And that was, again, 2005. I remember going to a conference and hearing about that. And then seeing in practice over the years since. It's very rare. But sometimes you'll have a woman that responds very negatively to progesterone. This is not very common, but when it happens, it really is frustrating on the part of the patient and for us too, because I want results always. And when you give someone something that's supposed to cause this and have this benefit, and they have the exact opposite, that's very frustrating. And it is for the woman, because a lot of times you go into your doctor and they'll prescribe this medication. You come back and be like, this made it worse. The doctor's like, no, it doesn't. It doesn't do that. And that's a pitfall a lot of doctors fall into. Be like, progesterone is always stops anxiety. Progesterone is amazing. Progesterone is the best. Progesterone doesn't cause that. It does. It can. Let me explain how this happens. In this image here that Jess is about to put up, it kind of sums up partly what we believe is happening. Because, again, we don't do nearly enough research in women. It's still pathetic. And it's hopefully getting better. It is getting better. But still, hopefully they'll do more research in this arena. what you want you to look at here is there's a thing there in the top middle corner there on the far right side that says pregnenolone sulfate. See, the thing about pregnenolone sulfate is that is an opposite reactor. It does the exact opposite of what allopregnenolone does. So let's step back and talk about the pathway again in that context. When you have progesterone crossing the blood-brain barrier, it's going to convert into allopregnenolone. Allopregnenolone binds the anxiety receptors. It's going to help reduce anxiety. When a patient makes more pregnenolone sulfate, though, instead, pregnenolone sulfate causes more anxiety. The thing is, that's even too simplistic because I don't want you all to hate pregnenolone sulfate. Pregnenolone sulfate is a neurosteroid that's essential in learning. Okay? You need it. I want you to have it. It's all about balance. If pregnenolone sulfate is allowed to go too high, that's where you're going to have a patient having more anxiety. And so it's always a balance. And sometimes instead of pushing down the allopregnenolone pathway with progesterone, their body's going to preferentially try and push towards pregnenolone sulfate instead. And so one of the things that I approach this with is trying to understand that pathway and why it's been upregulated. And so if you look in there, there's the sulfosyltransferase pathway that's been upregulated. A lot of people have sulfation issues. They don't handle sulfates very well. There's a metabolic thing in there, a genetic thing. Sometimes it's methylation, MTHFR plays a component in this as well. There's histamine intolerance. There's a lot of things that can kind of cross-react into this and cause this. So when I see that population, I really want to evaluate for other factors that affect the way that they generate, or it's called neurosteroid synthesis, their biosynthesis of neurosteroids. I want to look down those pathways and see if there's something they have that's slightly irregular. There's genetic irregularities we have. That woman is just fine when she's making natural levels of progesterone herself, but as she goes through menopause, these levels diminish, and I try giving it to her from the outside in. That external surge, as you would, me giving them from the outside in, and them having their other health issues, is going to trigger them to make more of that progesterone sulfate. And that's what we're believing is the possibility. That's the hypothesis that I have with that. And that's been kind of circulated around in medicine for some time. Again, not supported yet by enough research. I just wanted you to know why this may be happening and where the thought process is currently. There's a journal called Psychoneuroendocrinology that publishes a lot in this topic. And that's an interesting one to keep an eye out for. And I will be reading that, and I always read that. But as it is researched and fleshed out over the years to come, I will be bringing more of that to this podcast for you guys to help you understand, because you are a valid population, and if this does happen to you, and I know it, and I want to do my best to be as helpful as I can be for you as well. And then the final question, this is Dr. Melissa Hirschberg. Love that question. Why do people feel good in follicular phase when estrogen is high and progesterone is low? Well, Dr. Melissa Hirschberg, that was a good gotcha question. 2 years ago, I did an episode on just that, and I should do it again. You know, estradiol gets such a bad reputation, and I don't always help, and I don't want to make it to be bad. Estrogen is beautiful. We love it. Estradiol is an essential part of being alive. I need my estrogen. We all need estradiol. The thing is, and as you know as a physician, is that it's all about where it should be within the range and the cycling of it. So estradiol in and of itself is not anxiogenic, right? But we know that when you have it beyond a certain range, it's going to stimulate more the estrogen alpha receptor, or a certain range estrogen beta receptor activity. Remember, that's that alpha and beta receptor activity of estradiol, and those contribute to anxiety. So when a woman is cycling beautifully and her estrogen is within the normal range, we don't have anxiety. When a woman has estrogen superphysiological, it's going to cause them to have that. And this is going to be me going to the PMDD. For that woman who asked that earlier, what are we doing about PMDD? I'll get there. But this is for you specifically. It's I know I sound so dualistic. That's good and evil with estrogen and progesterone. It's so much more complex, and I need to be better at wording it that way, but I try and make it. It's hard to give complex concepts in a little short format like this and do a good job, but you're challenging me, and I appreciate that. I see that. Thank you. when you have a balance of estrogen and it is in the sweet spot and the progesterone is in the sweet spot, your brain chemistry threads that. If it's too high in the estrogen, too low in the estrogen, anxiety. If it's too low in the progesterone, anxiety. So it's not always going to be, progesterone solves everything. There's also the balance of estrogen. And why I'm kind of focused on progesterone a lot is because if progesterone could be normal and you're ovulating, that means estrogen comes down. If you're ovulating, progesterone comes up to normal and estrogen is here, we're good. I've fixed this without even having to talk about it. But we do need to talk about it because the logic stands and it's true, is that you can navigate a great cycle in this estrogen dominant first 2 weeks of your cycle. You can navigate great health in that window there as long as estrogen is in the right range. And so you didn't need progesterone there, but you do need it here to create that balance, because if you have estrogen drop down mid-cycle and now progesterone is dominant and there's not enough estrogen, you need the progesterone to offset the anxiety of low estrogen, right? And if estrogen is too high all month long, you have anxiety, so I need progesterone to balance the GABA receptors, right? So that is a good question. It's nuanced, but it is important to address that, and I do consider that is in my thought process as well, always with my patients, and maybe I didn't word it as well in that episode. So thank you for asking that question and bringing that up. I do appreciate it. Thank you guys for your participation in the podcast. A life with meaning is a life well lived, you know? And when you're able to be of service, it just gives meaning to life, I think. And so thank you for that. Thank you for being here with me. Thank you for taking time out and writing questions. Thank you for being here with me and sharing your feelings and what you go through. You all write such beautiful things. I love when you comment to each other. I always do. I always love seeing how you support one another. It's beautiful. And you guys all live around the world. And I see people from Australia talking to people in Ireland, talking to people in Great Britain, talking to people in, Kansas. It's just humbling to be a part of something like that, to be there. So thank you for letting me be part of this with you. And I will see you at the next episode.